Hello everyone, my name is Julia Dobbins. I work for the National Healthcare for the Homeless Council. Welcome to our webinar today, Assessing the Needs of Women in Medical Respite Care. This webinar is presented by the National Healthcare for the Homeless Council as part of our spring virtual training series, Her Health, Her Housing, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. A few housekeeping items before we get started. This is going to be a 60-minute presentation with the last 10 minutes reserved for question and answer. There is a chat box below the presentation slides for participant questions and technical issues. Please type your question or technical issues into the chat box at any time during the presentation, and we'll get to the questions at the end. If you're having any technical issues, you're also welcome to call Caroline at the council. The number is 615-226-2292, and her extension is 222. A lot of twos in that number. This session is accredited for one continuing medical education credit hour through Vanderbilt University Medical Center. Please note that the downloadable claim instructions are located in the CME information pod to the right of the presentation slides. If you plan on claiming credits, please download this document and follow the instructions. The claim code will only be available during this session and will appear during the last 20 minutes of the presentation. In order to receive credits, CMEs must be claimed within 3 days of the end of the presentation. So that's all of our housekeeping. I am thrilled today to be joined by two additional presenters. I have Carol Daniel here, who is a professor at Missouri State University School of Nursing in Springfield, Missouri, and she also works for the Women's Respite in Springfield. We also have Jason Emerson, who is the Executive Director of United Caring Services in Evansville, Indiana, and their respite program serves both men and women. Our learning objectives today are we're hoping to help you understand the gap in medical respite services for men and women across the country, to help increase knowledge of the barriers to care for women experiencing homelessness, and then also learn some strategies for how to expand your medical respite services for women. So this is not going to be a Respite 101 webinar, but I do want to take just a few minutes to talk about how we're defining medical respite to make sure that we're on the same page. So when we talk about medical respite care, we define it as acute and post-acute care for people experiencing homelessness who are too sick to recover from illness or injury on the streets or in shelter, but are not technically sick enough to remain in the hospital. So unlike respite services for caregivers, medical respite or recuperative care is short-term residential care that allows individuals who are homeless an opportunity to rest and recover and heal in a safe environment while also accessing medical care and other support and wraparound services. When we talk about respite, we think of it as 4 primary components. So clinical care to address the acute medical need, case management to help clients connect with community resources, integration into primary care and a connection with a healthcare home, and finally, self-management support and goal setting. So in medical respite, there is active involvement by clients in their healing process, and medical respite is really a time to practice health education and to do planning and prepare for achieving goals that they've set while they're in respite. So to give you a brief overview of respite nationally, the National Healthcare for the Homeless Council maintains a medical respite program directory. We know of about 70 programs in the directory, and the national average length of stay for a client in medical respite care is about 39 days. Also, in terms of program capacity, about 50% of the programs in the directory have 20 beds or less. So there are certainly some outliers across the country. There are programs that have 100 beds or 150 beds, but generally about half of the medical respite programs that we know of are 20 beds or less. So to give some context about why we're here today, why are we talking about women, and specifically why are we talking about women as we talk about medical respite? And a colleague of mine would say that that is the wrong question. I think a better question is, why aren't we always talking about women when we talk about medical respite and expanding respite services? And why aren't we always talking about the ways in which the experience of homelessness is gendered and the barriers to care that may exist for women that we may not be considering? In a lot of ways, homeless services are siloed by gender, and funding for homeless services are siloed by gender. And this becomes tricky when we talk about medical respite, because medical respite is still not a household name in the medical field. People are still learning about respite and getting on board with the value of respite. So a lot of times when programs start, when communities build their first respite programs, it is a collection of resources that already exist. And so if the most affordable option for starting a pilot respite program is to partner with your local homeless shelter, what do you do if your homeless shelter only serves men? And as we know, a lot of homeless shelters are set up specifically for men. So that's one barrier to care there. And then we also hear a lot of concerns around providing medical respite services for men and women in the same space as it relates to safety. I'm not sure if you were able to attend either of our webinars last week, but there was a lot of conversation around the staggering and shameful statistics of the number of women experiencing homelessness who are also victims of violence. And so in planning and developing respite programs, that comes up in conversation of wanting to create a healing space, but not knowing how to do so for women who have experienced violence, specifically violence at the hand of maybe an intimate partner. So often the complexity of that nuance becomes a barrier to creating services for women. And that conversation moves into, well, it's just too complicated, which is frankly a larger systemic problem we have in our healthcare system as it relates to meeting the needs of women, of identifying those needs as too complicated, and then therefore women as being just generally too complicated. This is a soapbox I'm not going to get on for the next hour. I don't think that was not one of our learning objectives for me to yell about that. So it's just a reality that I want to acknowledge, and part of the reason why we're having this conversation today. I also want to acknowledge that we're not going to be talking about just the best practices for providing respite services for women. And the reason for that is we are still figuring out what that means. Again, like I said, respite is still relatively new for a lot of folks, and this is very much a conversation that we're going to be having today about what does it look like to provide services specifically for women who are experiencing homelessness. So what we are going to be doing today is highlighting two programs who saw a need in their community for respite beds specifically for women and who created those services to fill that gap. And we're also going to be talking about community partnerships, staffing, training, challenges, and successes. So with that, I'm going to pass it on to Carol to tell us about her program. Thanks, Carol.
Hi, thank you very much. So greetings from Springfield, Missouri. Just wanted to tell you a little bit about our women's medical respite. Our philosophy is that it is helping homeless women find a safe landing place for recovery. And so as Julia was talking about the concept of who we are serving in that acute and post-acute care, we wanted to take it to how do we recover, and what does that recovery time frame look like. We began as a result of work from the students in the School of Nursing at Missouri State University. I work in community health, and we had a wellness clinic within several of the shelter populations. And back in 2011, we became very much aware of practice that has now pretty much been stopped. It's not totally gone, but where people would just show up at the door of shelters with acute needs for recovery, and the shelters not being prepared at all. As we did our statistics and we worked with those for a while, we decided we would develop a task force, and the task force was in place for almost 2 years. And then we did a pilot project in which we expanded and said, okay, who can we work with? And we chose to work with the women first. It was just easier for our communication with them to deal with sheltered women or women that needed some shelter. And our model base is really a shelter model, but we are an independent 501c3, so we are not under the leadership of a shelter, as Jason will talk about in a few minutes. And so we did a pilot project, and we established our program, in May of 2015. Wanted to show you a little bit of where we have lived. We lived in the Olive building, which is a 3-bedroom apartment. We had one homeless lady whom we tasked. We actually had several homeless women that did this particular task, but to be there during the nighttime because we wanted 24-hour a day contact person on the premises. And so we had 2 beds in that particular facility, and we lived there until December of this past December 2018, in which we moved to the O'Reilly Family Campus Apartments, which is both of those buildings were owned by the Kitchen Incorporated shelter, and they service mostly women and families and some men. So we are now in this new facility, which is great. It has 3 beds, but it is built on a tiny model, home model, and so it's a very compact facility. So we literally have 3 beds, not 3 bedrooms. And that was one of the things that our women loved, was having a place that they could call their own for whatever length of time they were with us. A couple of things that I think you should know about our facility is that we have a 21-day policy. We will extend that as it's needed, but it's for medical necessity. And for the most part, about 14 to 16 days is an average stay for our women. We have had a number of women who have stayed much longer than that due to medical complications. So I don't want you to think that we only will take them for 21. We will extend that more. So women must have an emergent or a chronic illness, and that could be from injury or illness or surgeries, and there has to be the medical necessity versus a psychological necessity. Obviously, there's a lot of mental illness within the homeless populations, and so we know that there's a lot of mental illness that we have to confront and deal with. We provide transportation and medications for those that do not have any access to medications. We try to, one of our primary goals is to get a primary care provider in place as soon as possible, and there is a free clinic, it's called MSU Care, in which they can get medications for free. Otherwise, we have to wait until Medicare or Medicaid to kick in, and those will take sometimes 6, 8 to 12 weeks. And so someone who does not have any medications, that becomes very much of a barrier. So we will try to help with those medications. And then, of course, nutritious foods and that bed to sleep in does a lot to promote health. And then once a woman is able to see a healthy lifestyle, she oftentimes wants that housing. So we have that collaboration that goes on with permanent housing or some temporary services that are needed. And I'm going to pass the gauntlet on to Jason. There you go, Jason.
All right, thanks. So I'll give you just kind of a brief outline. UCS started in 1991 Our mission provides values-based, low-barrier, sustainable, high-quality homeless shelter services and solutions. So we are a homeless shelter in which we started a medical respite program. It actually goes back to, if you look at the timeline, 2005. Since that time, we had a need in our community to address the unsafe discharge of patients in our community. Several things were iterations that were not successful. 2011, much the way with in Carol's story, the University of Southern Indiana, a class had a capstone project working with Deaconess Hospital, one of the larger providers in the area, to collect data regarding homeless discharge and hospital costs. And so with that capstone project data now, plus, and I'll mention this, enthusiastic people. So enthusiastic people in the hospital, it's the right personality, the right people said, well, let's stop. It's almost been 10 years. Let's stop talking about this. Let's actually do something about this. So that partnership was with UCS. We started a men's respite program, as was easier for us, but also created some challenges that we have faced recently with 6 beds located in our men's shelter. That was in 2014. Then in 2016, expanded to have 4 beds for women in our women's shelter. So we have a separate location addressing that safety issue. And then that's our women's shelter with 20 beds on the 2nd floor, and then these 4 beds on the 1st floor. I can get into the details. They can stay up to 6 weeks, and we provide all the wraparound type services. We did have one challenge with funding, which was a result of kind of that 2-tier process. I don't want to say women were looking at as a secondary population, but since it was a secondary opening or expansion, not the primary thing we started with, it has sort of seemed like a tack-on initially. That culture is changing, and everyone sees the value, the more women that go through it, see it on equal par, but a lot of people think chronic homelessness, homeless needs, they think men, not necessarily women, and that's just cultural. It's a residential model, makes the flat rate per diem. We provide all the wraparound services. In that original thing, there was a task force that included UCS Case Management, USI Nursing School, and various other people in the community with the hospital's case management. That task force started during the pilot year and has helped guide and continue the program ever since. So that's us in a nutshell.
Great. Thank you, Jason and Carol, for giving us an overview of your programs. So what we're going to do now is move into some discussion about each program and ask more direct questions. So what we want to know about first is specifically around community partnerships. I had mentioned earlier that because there is no single source of funding for respite currently, a lot of times respite is a combination of a lot of resources that already exist in a community of homeless service resources. So I want to know from both of you who you feel like is important to bring to the table to start a respite program, what your relationship is like with your local homeless shelter. Jason, I think that's a little bit different from probably Carol. And then also I want you to share a little bit about your referral process. Who do you receive referrals from, and what does that process look like? So Carol, we'll start with you. Carol, I think you're on mute.
And I was on mute. Thank you. Okay. I think you always have to start when you're talking about a task force with the role of the homeless. And we have talked with a lot of homeless women. We've had a lot of homeless women that have been part of our staffing and our volunteer services. And so we have asked those questions of what do you feel like is needed and how do we access those. With our task force, of course, we had Missouri State University, the School of Nursing component. We've also had a lot of other assistance from the university departments, from journalism to pre-med to social work and various others. The Kitchen Incorporated is a large shelter population here in Springfield, as is Salvation Army and Victory Mission, specifically Victory Square. Those are very much played into our discussions with the original task force and helped us determine how we wanted to progress as far as meeting the challenges of homelessness and a possible respite situation. After, and I'm going to look at your question again, describe your relationship with the local homeless shelter. When we did the pilot project, and then after the pilot, we have stayed with the Kitchen Incorporated as a very strong collaborating partner. And recently, both Salvation Army and the Kitchen Incorporated combined with us for a grant, and we were all three placed on a particular grant together. So we're working towards case management and more involvement from the medical nursing side as well. But our facility is housed within the Kitchen Incorporated emergency shelter. And so that's a shelter that has a potential population of 50 people. So, but at the moment, we're all in our individual apartments, and so there's not a lot of interaction other than just saying hello to your neighbors, that sort of thing. Who sends referrals for our medical respite program? The hospitals. We have a clearinghouse for social services, which is called One Door in Springfield, Missouri. And there is it's not an emergency shelter, it's a nighttime shelter, a 12-hour shelter for women that goes from 7 at night until 7 in the morning, and then during the day they have to be on the street with all of their belongings. So Safe to Sleep and One Door kind of combined. They will frequently call us and say, we've had this lady that's been in an emergency room for the last 3 days, and they keep sending her back to us. And so we will partner with them and bring the lady over to us as well. Also, we get referrals from rural behavioral health, or they have patients that are in the hospital, and so they will make a referral as well. And that's how our referral systems work. I just want to point out the picture on this particular slide is a volunteer who actually had come from Oklahoma to clean up our facility and make it beautiful for our women before we ever started our program in May of 15, I'm sorry. And I have to highlight who's at the table are those volunteers that come along beside, if they're college students or the community workers. And the volunteers are just the shot in the arm that you need for encouragement, both for the clients as well as for the staff. And so Jason, let's see if I can get that over to you.
Okay, so I kind of broke it down with who should be at the table, looking back at the task force that started here and how we progressed forward as we expanded services. I won't need to highlight, as Carol said, the consumers, the people that we're serving. We call them guests, just to kind of always focus on the idea of hospitality, that they are our guests as well. Not quite as clinical as a client, but they're guests. So, we're always asking, involving, getting feedback, not only in the original provision, but as we continue services. Also, advocates, people have more than just money to give, and these could be your volunteers, as Carol said, but also the social work, nursing staff, case management staff. The more people that are aware of respite services and the importance, the greater chance that it kind of gets out. If you can affect the culture of the other providers or other agencies. So, I kind of separate that out as kind of an advocate. Then you have the funders, those who might financially support the program. Those may be the service providers, hospitals, or whoever, if you're able to bill to insurance yourself. But funders, as Carol had mentioned one of the foundations, which I did not put as a logo, we have a mishmash of various foundations across the United States and grants that if I put every logo up there, I wouldn't be able to put my 50 thing at the end. There's just a lot that goes into it, but Deaconess was who helped start the pilot program. St. Vincent and Ascension Compass Health, there are major referrers. We take referrals directly from the hospital. So it's working with case management in the hospital. They would have their rules, their discharge plan, what needs to be done, whether they don't go anywhere for 72 hours. Then we pick them up or they get brought here. That's arranged, and then we kind of move from there. So the direct referrer would be the service provider. We do not take secondary or tertiary recommendation or referral from our own programming or from like another shelter. It is direct from hospital to us. But that gets into kind of the opportunity network and working with other shelters. We want to provide wraparound services, OT, housing, employment, whatever it may be that the lady needs. She can stay 6 weeks or based upon her discharge plan and her goal setting, but 6 weeks is kind of your typical IV treatment. So if she needs 6 weeks, she gets 6 weeks. And that's within our rule set, our shelter where the ladies are housed. We allow 90 to up to 180 days stay there. So 6 weeks, even within our own shelter rules, we're very open, as it would say. Stakeholders, that's not only just what we would call the committee, but that's everybody that's above and others. Political bodies, we want to involve all of our local schools. We have 3 good nursing programs and tech programs here, volunteer groups, faith communities, as long as many people in as many areas, Rotary clubs, Kiwanis clubs, whatever you have, get in front of them, talk about it, share how it's so important, not just with health outcomes and cost avoidance, but safety for a person that we each need the way to do it. And then my kind of little pithy thing there at the end is we partner with people, not corporate logos. And, of course, I wanted to include some corporate logos in there. So that's all I got. And teamwork makes the dream work.
Always. Great. Thanks, guys. So for our next question, I want to talk about staffing of your medical respite program. What type of staffing do you have? You both talked a little bit about the role of volunteers in your program, but in terms of staffing, and you may do this as well for volunteers, what training do you find most important for people who are working in your program? Jason, Carol, I'll pass it to you.
All right. So we have a very small staff. We have 3 contracted staff members, one that works 40 hours a week, 40 hours a week, and then 2 that share the role every other weekend. And so they work 30 hours for a total of 70 hours per week. That is contracted staff. And those workers are looking for, they do housekeeping chores, they do any management of doctor's appointments and making sure that taxi vouchers are prepared, those sort of things. They coordinate if there's home health services that are there, and then they keep up with the volunteers. And basically our 40-hour-a-week person is the one that's responsible for that. Then we have our volunteers from the universities and from the community. They may be nurses, they may be just a college student that, or not necessarily a college-age person that just wants to come and volunteer. And then we have the collaboration within the shelter staff itself, where we are housed, specifically with our security people, and that's why we can leave the apartment itself in safe hands within the shelter, because we have that collaboration with that. Our staff have the CPR training. We've done some conflict management training, and with NAMI, the mental health work group. And then there's some nonprofit development that's going on locally, and we have gone to several of those training sessions. I would say if there's anything in 2019 that I want to do with the staff, it is more training and education. So Jason? Oh, I need to push. There you go.
And I had to take myself off mute. So a lot that you'll see up here is kind of a laundry list of things that many should be familiar with that's in this webinar. If you're not, you really need to be informed in this and dealing with homeless services or respite care. We do some of these as in-service as well moving forward in 2019 into 2020. We're developing a greater training methodology. But as far as staffing goes, we actually have full and part-time staff that cover our women's and both our respite programs. We have about 5 or 6 staff people, full and part-time, that cover those hours. We always, if we have a guest, we always have staff on hand, during the day to help. There's a case manager that is also working with them that takes the referrals and does a lot of the navigation. And then since we're housed in 2 locations for the men and then for the women, there's the regular overnight shelter staff, and then each one of those programs have, program directors and case management as well. So where most of the needs of our respite guests would be addressed during the day, they do also have some maybe evening medication management or things of that nature that other staff continue. So we are trying, we're not 100% successful, but we're trying to engage a lot of these things across all of our staff for consistency and safety and comfort for our guests. So, the idea is really just kind of the trauma-informed care and, helping that person, create their goals and their plans. Some of our care staff might not get involved in all of that as much. We don't get a lot of maybe CNAs, even though we're a residential model. We get some people with previous CNA experience or home-based health services, or those that might have been, care sitters, with people. We do want people with some of that background and how they might treat somebody and kind of understand, maybe, difficulty that someone's been in, but also health crises as well. Really, and then for case management, it's getting into, like I mentioned, the wraparound services, substance use, mental health, housing, employment. The greater education we have, the greater we're able to meet the needs of people. And in the previous thing, one thing I've been trying to also engage is insurance companies directly, and that has, maybe that's one of the challenges later. That has not been easy. Maybe I'll talk more about that later, but we do have some good Medicaid representatives and some people that work, frontline services. So maybe as advocates, they don't necessarily make policy or control the purse strings, but being able to get people insured and get connected to those resources, you need to have those people as your friends. So a little bit about staffing and training.
Thank you, Jason. So our third and final discussion question, we really sort of want to dig deeper into why it is we're having this conversation today and talk a little bit about developing medical respite specifically for women experiencing homelessness. So if you could talk a little bit more, both of you touched on this a little bit, but why specifically respite beds for women and what challenges you've faced in developing and funding these services, and then just key considerations for providing these services for the women in your community. I do think it's tricky when we're having these conversations because we want to make sure not to make broad strokes about women in general. So we're really just focusing on what is it that you saw or that you see around the experience of the women in your program who are homeless. Carol, if you'll start us off, please.
All right. I specifically put this, these packages on this because I want us to celebrate women, and we have had parties and fingernail fingers, where you're putting nail polish on and doing hand massages and doing things that women specifically enjoy doing. That I just think that is really one of the keys at finding out that there's a relationship between the workers and the community and our guests or our clients. And I, like Jason, we started out using the word guest most of the time, and because I am a community health nurse, it's clients all the time instead of patients, and so I pivot back and forth between those phrases, but I appreciate Jason saying guest because that's really who they are. They are our guests. The question is, why did you decide to create respite beds specifically for women? And I think that the whole idea was that we really felt there were more women in need of continuing services. I think oftentimes men have a way of, obviously if they're very acutely ill, they need services as well, and I'm not at all saying they don't. But many of our women end up with long-term respiratory issues, and there's just so many gynecological issues and diabetes that being homeless in a tent population or going sofa surfing or living in your van, those issues just are not being addressed. And their longevity is more than the men. We need to keep them healthier. And we need to keep those men healthy. Please don't misunderstand me on that one. With a partnership with the kitchen, we were able to satisfy a safe place for us to be. And so that was just, they were reaching out to more women, so it was just a logical conclusion that we would reach out to women as well. I think that you cannot talk about challenges unless you talk about two different things. One is the identification of homelessness within the hospital scenarios. The hospitals, for the most part, have a don't ask, don't tell policy, and they don't want to identify who the homeless are because then they would be required to do some follow-up work. And I have had long discussions, especially with nursing students or even nurses within the hospital. You are saying, oh, that person's not a homeless person, and I'll say, yes, they are. They actually came from our place back to you because they needed some more care, and so please, keep us in your loop. So I think that a lot of times it's that identification. A homeless person, for whatever reason, does not like to say, oh, I don't have a place to live, or I'm living under this particular bridge when they're in the hospital. And so frequently they are released back to the street after having 3 stents, heart stents put in, or having IV therapies, or having pneumonia. And so people within the hospital setting not trying to not be aware of the populations, they're just not asking the right questions. So I think that's one of our largest consideration and challenge. The other large challenge for us is funding. We are not funded through the hospital. We are not funded through the shelters. So we find our own funding, and that comes mostly from private donations and then a few grants. I will be the first to acknowledge that most of the board members are nurses and in healthcare, and we were not taught very much about fundraising, and that is one of the areas in which I have learned a lot, but I have a lot more to learn. And so I would love to tap into Jason's resources for those funds if they go nationwide especially. We have had fundraisers that have been involved with high school workers who have seen the need and have said, hey, let's do a rally for the homeless. And they've done marvelous programs for us. We have a road rally every year, and we've had a big dinner, which was funded by a corporation in town, and then we were able to put our word out there and get information about that. We have a fundraiser coming up with, actually it's more of a let's tell everybody who we are and what we are, but we will also have some profits coming off of that, which is the Go Girls Run in April. So there are things that are going on frequently to help put the information out for the community to know what we are doing. and hopefully they will contribute to that. Also, we're learning about online giving, and so our CFO, the Community Foundation of the Ozarks, has processes in which you can give online, and we're learning how to make those online contributions a lot easier for the millennials that are giving now at this point. So I think that's really pretty much what you were asking for. So if you have any questions, be sure and ask away, all right? And Jason?
So I mean, to go back to the question, so why we started the respite beds, I kind of broke into sort of 4 bullet points. Really, it was just kind of by the numbers it was needed. As I mentioned, we started as a pilot program. It was a staggered start, kind of with men, and I guess the pros of that was, hey, we got one started after 9 or 10 years of talking about it in the community. Kind of the bad thing of that is it wasn't, I mean, and that was out of necessity, it wasn't started together. And so what we found in the pilot program is that as many referrals for men that we were receiving, we also had for women, and so no solution for that. So yes, it was good that it was coming to the community, but it was bad that now that it was coming to the community, it was coming with the negativity that we weren't serving 100% of the population. Because homelessness is, you know, male homelessness, chronic homelessness, right, is considered usually what pops in people's minds. So, you know, by the numbers, it's important, it's needed, it's out there. The other thing is it's not the same thing as serving men. It's not a one-to-one. Again, I would encourage, if you want to do both, do not start them separately. Separate locations, I believe, and that's how we do it, is important. If you serve women, obviously, start the women's program first, if that's your primary goal. We're kind of still learning how to do this, to communicate the importance of women's respite as a part of the need of respite services, aside from men's respite. And the way we do this is kind of the different health needs and different challenges. You know, some women's needs are just different than men's needs. The lens for the importance of women's health care, which I find this interesting. I'm the one saying this, but this is what our guest and a lot of people educated that I've seen is the different health needs and challenges. You know, depending on what's going on in the community and other resources you have available, shelter services or other inpatient stay, chances are if it's been started, it was probably started for men first. So there's probably that need in the community to address those needs. And in our experience, it's what separates also serving women, and I don't want to generalize, you know, the men we serve are thankful, but it's this idea of trust and comfort. We were fortunate to be able to put it in a separate location, to have it be relatively quiet in 4 beds and, you know, kind of have a nice area that were in previous pictures. The importance of relationships seems to be an important thing to focus on. Once they've, you know, once a woman we serve has kind of let us in, it takes on a little more of a familial dynamic at times than it does with the men we serve. And some of the challenges that women face that we found in our community, that they don't always have some of the same structure and support systems, and I'll talk about that now, some of the challenges. In our experience, as I put it here, let me advance the slide. And this is in our experience, again, not to generalize, we found that women in respite tend to lack the adequate support system, which led to and exacerbated the kind of their vulnerable state, where in the men that we've served that they're a little more familiar with what's going on in the area. A lot of the women we serve have a need for greater care and time to then get connected to the resources, so they don't have a familiarity with what is available for them to help them, to empower them. It starts with knowledge. They have very little knowledge, where the men might be a little more pros at it. And given that, with the challenges of the need, the women that we serve benefit from more intense case management and longer stays. So where our rules at the beginning say, yeah, 6-week stay for men for an IV treatment, that might meet the medical need, or medical respite, but what we have found is advocating and trying to argue for longer stays for women, because sure, we might be able to help them recuperate and recover, but they need more than just that. You know, it took us a couple of weeks. I mean, it takes a little longer to get them in the bed and then to get to know them and to break those barriers down so they're recuperating, but they're not going to be in that good condition when they leave unless they start to overcome some additional barriers. As far as other, you know, not to get into the weeds, but funding as well, depending on who you're speaking with, whether it be foundation funding or your health service providers, especially health service providers, how their budgets are done, that maybe some of the money they may be giving you in community outreach does not directly affect the bottom line of their ER or their nursing floors or their social work department. It's all budgeted separately. So when you say, hey, we're saving you X amount or you're cost avoiding X amount, the lines across those budgets are not communicating. So they're not realizing on paper those savings, because that's over here and their community money is over here, and they're not, this is, you know what I'm saying. So the good thing to do is kind of, again, back to the partner with people. You want to partner with the financial decision makers and let them understand how that's affecting, and having the floor advocates of social work and nursing, you want to have that as well. Communicate your success stories as well as the health and housing outcomes. You want to translate dignity into cost avoidance and savings, and prove that with data. And you know, as Carol has said, people are coming at this from different backgrounds. We are about 50% funded from providers in the community, and we are 50% funded from our work we do with fundraising, grant writing, and you know, outside hospital health system referrals, whether it be flat fee or per diem. So to have a part of your task force or that team, not only are well-intentioned, good-hearted people, but you know, some of that business administration and grant writing, you know, is helpful, of which I happen to know how to do. So that's a benefit to us, but that's not always for everybody. So that's enough of that.
All right.
So, Carol, I'm going to ask both of you just briefly to, Jason, you brought up the importance of being able to talk about success in your program and share stories of success. I want to do a quick time check. We have about 12 minutes left, and I want to make sure we have some time at the end for questions. So if both of you could share some stories of success, maybe in 2 to 3 minutes, that would be great. And Carol, you can start us off.
All right. Well, I'll try to take just 2 to 3 minutes here. It's very difficult to just give you one story, because every guest that we have brings so much and shares so much of her life and her story, and each story is so important. But just last month, a lady sat on the sofa in our little space, and she looked at me and she said, "Thank you. You restored my determination." And to me, that, in a nutshell, was what we're about, and it tells her story. As she came to us, she had been in a housing crisis for 6 or 8 months. She has lost, and she's been chronically homeless for many years, but she had lost 60 pounds over the last year, very tiny, older woman, and very fragile with an upper respiratory infection. She stayed with us for 2 days, and I was sitting there looking at her on the third day, and I said, she's got to go to the doctor's office today, which she had an appointment for, and they immediately put her in the hospital for the flu because she had regressed into the flu and into pneumonia. not by anything that had been wrong with what we were doing or what she was doing. She continued on with us. She was in the hospital for a little while. What we normally do, if they stay 24, 48 hours in the hospital, then we readmit them as a new client. And so she came back to us after almost a week in the hospital and was continuing to do very well. And then she had a diabetic setback and ended up in the hospital again. And then the third time, we were finally getting a successful outcome with the fact that she started gaining weight. Her blood sugars were stabilizing. Her mental outlook was astoundingly bright, and she was just a breath of fresh air. She has just recently gone to a hotel as she waits for her housing because we just could not keep her any longer. We'd already had her for a month and a half, and because we only have that 21-day window, that's kind of where we're faced with issues, and we may have to raise that, but when you only have 3 beds, it makes it a little difficult to do. So that's our story. You restored my determination. I think that's what we all should be about. Jason?
Yep. Make sure I'm not on mute. So this is Paulette. That's a little bit of a grocery run that she was doing. She was still a respite guest with us, but this is more toward the end of her stay. I want to bring I was talking about, translating dignity into data. So if you want to look at Paulette by the numbers, she was with us about 40 days. If it's a $1,200 room stay at a hospital, so that's $42,000 is Paula right there, cost avoided or cost saved. And that's not all. That's your direct cost. Why did she need respite? Well, she needed it because she'd had for some time debilitating medical issues that had been requiring continuing home therapy. So she'd gotten worse and got to that point. But unfortunately, once it got everything happens, you got housing crisis, you get health crisis. So even in our homeless, state, our home and trailer had been condemned, and that was contributing to a lot of her health issues. And in the midst of it and going to the hospital, she was one, and many are, reluctant to admit homelessness. So they have one crisis they're coming out of, and now they're experiencing another health crisis. And doubling those on top was very difficult for her. She felt really, kind of down about that, and many do. But really, thanks to respite, she had that place to recover, start to receive that home therapy. She had the strong support system. She started to learn information and, get connections with people. She'd been living by herself, in this trailer. She started to have greater social connection with, I believe we had, during some of her stay, another respite guest, and then we have our night shelter guests as well. During the stay with us, she was connected to occupational therapy and physical therapy. She applied for SNAP and Medicaid. She came to us uninsured, so we were able to get her insured. She was able to get her Social Security increased, and all of that, again, out of health and housing crisis, she was permanently housed. So she was healthier than she had been, and so much. When she entered us, she happier, smiling, sweet lady. So, if you want to talk cost avoidance, I can give you days saved. If you want to add all those other things up, her smiling face, what we see there, we miss her, and but she was lovely, and, we have other stories like that, but, it's just be inspired. One of those stories once a month, once a year is enough to make it all worth it.
Great. Thank you guys for sharing these stories. We have just about 6 minutes left, and we have several questions in the pod down here, and I want to make sure we get to at least 2 is my goal. One question that came up several times, both of you have smaller programs, and people are interested in knowing how you prioritize your referrals into your beds. And do you struggle with having full beds and people who need those beds? And is there a tension between your referral source in your program when they need a bed and you have somebody in that bed who's not ready to go yet. So if you could talk briefly, real briefly about that, that would be great. Carol, do you want to start us off?
All right. Yes, that is a huge problem because in our new facility, we have stairs that have, it goes up to a large room that has 2 beds in it. Our downstairs has a kitchen area and living space and 1 bed. And so if someone has oxygen or if they cannot traverse the stairs safely, they have a walker or a wheelchair, that would prohibit them from being upstairs. And we have several people that we have had to decline just in the 3 months that we've been there already. That is very troublesome to us. We normally go on acuity and trying to determine if this is something that is manageable within our setting, then we want to facilitate that and to facilitate their recovery.
So for me to answer that is not now that we have a women's respite offerings. You know, the issue was before is we would get a referral for women and not have that service available, having been known for medical respite. We usually operate at most around 50% capacity. The women, you know, we have 4 beds there. We've had 2 at a time, and there's 2 rooms with 2 beds each. So at that time, they each would probably really get their own room and then kind of a shared ADA bathroom in between. The men, it's 6 beds in a slightly smaller area. Usually, you know, even though there's 6 beds, about 5, it gets pretty busy in there. So if we get to, you know, 3 beds there with occupancy, you know, 5 out of the 10, you know, we're happy to operate at that level. We've had up to 5 men at a time, but usually when we're at that level, you know, that's one person that's just here for maybe 5 days. We rarely had an occasion, maybe one time, and this is only for men in the history of our program, where there was waiting for someone to leave so someone could come in. Usually we do pretty good. One thing we try to work with other shelters in the community to call them as well and talk about some of the people that have come to visit them, maybe with health issues, and I could have covered this in another area, to identify, was that really a safe discharge or should they have come here? And was that due to lack of information, lack of comfort? Where was that gap in communication? And if someone goes to a shelter and we hear about it and we'll get a call and they're back to a hospital, to the ED and admitted within 30 days, that's something that the hospital really wants to address so that, to prevent that. So we would take a few additional people. I would like for that to be more of a problem because that means our services are being utilized more.
So for the sake of time, I think we're going to go ahead and wrap up. If we didn't get to your question, which I think we have several questions left, what we're going to do is I'll send these questions to Jason and Carol, and they will respond to them. We'll do a written response and send it out to everybody who's attending the webinar today. So you will get a response to your questions. Also, somebody asked about locations for specific respite services, and we will send a link to the directory of respite services as well. And I will also include language around how we're defining medical respite because somebody asked about that. Thank you, Jason and Carol, for being with us today. We really appreciate your time and the work that you do. A link to the archived webinar will be available on our website at nhchc.org at the conclusion of the spring virtual training. I do want to give a brief shout out to the other webinars that are happening throughout March, tomorrow and then also next week. We're going to be talking more about the experience of women who are homeless, specifically queer women, and the experience of women of color, and also talking about safety planning and cervical cancer screening, just lots of really fantastic, relevant content. So I highly encourage you to attend the rest of our webinars for the rest of the spring virtual training. Please copy and follow the instructions to claim your CME credit for this session. The claim code will only be available now, and credit must be claimed within 3 days of this webinar. An evaluation of today's presentation should automatically appear in your browser when the webinar closes. If for some reason it does not appear, please copy and paste the link provided on the closing page to access the evaluation. Again, thank you so much, Carol and Jason, and thank you guys for attending today's webinar. Take care. This webinar is now closed. Thank you.